Greetings. Welcome to the Teaching Value in Healthcare Learning Network. Join us to hear leaders in the field share practical, tangible advice for how to develop engaging curriculum and health system innovation to train a new generation of healthcare providers from diverse specialties and professions skilled to deliver high-value care. With national concerns about rising healthcare costs as well as overuse, underuse, and misuse of medical care, it's time for educators to convene and address these issues. The Cost of Care and ABIM Foundation have created the Learning Network as a space to share ideas, educational materials, and strategies in an open forum. Our goal is to discuss ways to get started, implement, and sustain feasible innovations in teaching value at your institutions. The Teaching Value in Healthcare Learning Network will have three major components. Monthly webinars such as this with on-the-ground national leaders that you're going to hear from in a moment. The sessions are the third Thursday of every month for 30 minutes at 12 p.m. Eastern Time, as well as discussion groups and tools for educators on our shared Google Drive that you can access at bit.ly Teaching Value Network. There we have shared educational materials from across the country as well as publications and presentations. And as some of you know, I want to thank the viewers out there who have actually completed our evaluation survey that's in the field. We have about 50% of our sample completed, and so if you are watching and have received a survey, we would welcome your response on how we can help you better improve value at your organizations. So today, I'd like to introduce myself. I'm Vineet Arora. I'm the Director of Educational Initiatives at Cost of Care, and I'm moderating today's webinar. Today, we'll be sharing an innovation in teaching value, as well as discussing in-depth practical components of implementation and how to obtain buy-in, as well as resources needed and advice for feasibility and sustainability. Now, we're honored to actually have two speakers with us today. The first is Brandon Combs, who's an assistant professor at the University of Colorado. And Brandon actually is a primary care physician and general internist, actively involved in medical student education, and his academic interests include medical education, evidence-based medicine, as well as decision-making around cancer screening and high-value care. He's going to be joined by Tanner Caverly, who's also a general internist and a faculty at the University of Michigan Medical School, Ann Arbor VA Medical Center, and he actually had completed his training at the University of Colorado, served as a chief medical resident there, as well as completed a primary care research fellowship and a master's in public health. And together, they actually co-founded the nationally recognized Do No Harm Project in 2012, which has received a myriad of awards, including from the ABIM Foundation, as well as the American College of Physicians, for its innovative approach to teaching trainees about medical overuse. And this has been so successful that this approach has actually been adopted nationally by JAMA Internal Medicine. So at this time, I'm pleased to welcome them both to the Teaching Value Learning Network, as well as turn it over to, why don't we go ahead and start with Brandon, and let us know a little bit about how you guys got started, what is the Do No Harm Project, and really take us back to what's the impetus for this project.
Yeah, absolutely. And thanks, Vinny, and thanks for pulling this together, and thank you so much to the ABIM Foundation, as well as Cost of Care, for having us today. We know that there's lots of people around the country doing great things around teaching high-value care, and we're very excited to share our perspective on what we've done. So Tanner and I, we were residents together, and we finished residency here at the University of Colorado Internal Medicine in 2010. And around 2012, we kind of put our heads together after Tanner attended a conference in Boston called the Avoiding Avoidable Care Conference, and we learned that there were lots of people who were struggling through these issues of how to talk about high-value care, how to teach about it, and what are the things that we can do about it. And we felt like there were bad care, but they were being harmed from these things all the time, and it seemed like there wasn't a common language around it. There wasn't a clear way to bring these issues up and talk about them. And so we wanted to do something about that. Now, we were we had just finished residency. We weren't really sure what we were going to do or how we were going to do it, and so we wanted to start simple. We felt like we could do something. We were very passionate about this, and we were thinking about what could we do, and we thought, what a wonderful thing to simply describe these instances of care that, again, were well-intended, but were nevertheless unnecessary because they were, on balance, probably going to be harmful. And so we wanted trainees to basically describe these experiences through clinical vignettes, which was something that felt simple, it felt doable, because we know everybody is very busy, and we didn't want to overwhelm anybody. And so we basically went to an outpatient rotation at the Denver VA, where we recognized that trainees weren't working too hard, they weren't being burdened by overnight call necessarily, and so on. And we pitched the idea that overuse is common, low-value care is very common. We're all seeing it. We need to start describing it. We want to give you guys an opportunity to do this. And so that's basically what happened. And since then, trainees have been writing about instances of medical overuse, low-value care, the harms that can come from it, and the evidence that informs how we can do better to take care of our patients.
That's great. And Tanner, maybe you can highlight a little bit about, you guys were both residents, so how, you had this kind of idea. Who did you first go to, and were there people that you needed to go to get the buy-in? How did you really get the leadership behind you on this idea?
Okay, yeah, thanks, Vinny. So I was we started this after I was a chief resident, and so we were both trainees at this program. So we were both well plugged in with the faculty, and we knew the faculty well. We were on the ground level with the trainees, and we were kind of really plugged in, and so I think that was a big part of this. And so we knew who on the faculty taught evidence-based medicine and had a passion for thinking about value, and so particularly there was a culture of critically assessing the value of the care we gave to patients, and maybe a tiny counter-cultural element at the Denver VA. And there were a couple of people there in particular that really were well known and respected for being evidence-based medicine teachers, and that's a core element of what drove us and our motivation for this project. Is we felt we needed a hook to, we viewed these vignettes and these stories as a powerful hook to engage residents and trainees about talking about evidence and talking about value in medicine. It was a way for them to take a deep dive and reflect on their personal practices and what cognitive biases and their medical culture, the role that played, and the care that they provided, and reassess common care. So I think a big part of it was being plugged in, being knowledgeable about who taught this, and so we really, I think we went to 3 people in particular that were engaged in teaching evidence-based medicine, and started talking to them. Is there a place for this? How can we inject this into current efforts? And it really wasn't a big ask, and we can talk about perhaps next how practical and easy some of these first steps are.
No, that would be great. I'm thinking about medical educators. There's a lot of courses and resources. People are trying to figure out, well, how can we teach this? And obviously, it's great that you guys had some willing faculty buy-in. A lot of people talk about time. Where do you get time in the curriculum from? Especially in busy residency programs. And so I was thinking, at least with this writing stories, this seems like it could be laborious, so can you tell me a little bit about how, and I'll toss this one out to Brandon, how were you able to kind of streamline this and kind of be, make the sell that this is going to work out, and not kind of squeeze out other things in the curriculum?
Yeah, that's always an issue. Anytime you try to do something different, one of the first things you'll hear is pushback is, well, where in the heck do you think we're going to have time to do something like this? And so we were thoughtful about that. We wanted to be sure that wherever this was introduced, there would be dedicated time available. This would slide in nicely into things that were already going on, and so that it would be paid attention to and taken care of over time. And so that's why we chose this particular rotation where this culture existed, where we felt like the environment would be supportive, and that it also occurred in a situation where house staff weren't running around feeling like they were completely overburdened by patient care. And so that was the first step. The other thing that I think we recognized at the time, certainly we've recognized this over time, that such a central element of this process is self-reflection. And I think some people hear that and they say, oh, that sounds hokey or something, but in fact, self-reflection is evidence-based. It's very clear that this is one of the important ways that human beings learn. And look, it takes time. It's a very slow, very deliberate effort to reflect on what happened. What happened to my patient? Were they harmed? Were they almost harmed? Was what happened avoidable? Does it just feel like it was avoidable, or is there actually some evidence that would indicate it was indeed avoidable? And then thinking about what can we do, what should we have done differently? What can we do differently going forward so that we ensure we're providing the best care for our patients? And so that was one of the major reasons why we approached the leadership on that rotation and asked for a writing day, which is basically a day free of clinical duties to do this because it takes time. We were concerned that if we didn't provide protected space for our trainees to sit down and think about very carefully what happened and to write very carefully about what they think could have gone better and what they could do differently going forward, that this wouldn't be a meaningful exercise. And so, so thankfully, again, the culture was such that the leadership there said, you know, this does seem valuable, and for trainees who volunteer to participate in the Do No Harm Project and write up a clinical vignette, we will provide for them a day free of clinical duties to do this.
Well, that seems like an impressive incentive for any house staff to participate, and also, you know, really a commitment on the part of your organization and your leaders to say that this is front and center, which is really, really great. I would be curious, you know, not everybody's a writer, you know, I think we are surrounded by wonderful physician writers in the media, and how well they're able to really channel, you know, the thoughts that we have and really inspire a movement. And so can you talk to me a little bit, maybe Tanner, about, you know, what kind of resident is committed to this, and did they need a lot of help with the writing, or was it something that came naturally to them?
Well, I'll just, yeah, that's a good question. I'll piggyback on some of the things that Brandon said. You know, we really ended up viewing this day off as kind of an initial hook, and almost in a way it felt a little bit kind of not sneaky, but you know, we gave them this day off, but really we were really impressed with a lot of the quality of the writing that they gave us and the quality of their work, and I got the sense that many of them, if not most, and Brandon can talk to you about the numbers that at Colorado that have been participating over the past couple of 3 years. But many, if not most, spent much more than a day with this. They didn't just, so once we got them hooked, once we got them to think about this story of a patient that may have had a harm, you know, this is a patient safety issue, this is optimal care, this was a voluntary experience, and they didn't have to do it. They did get this day off, which was the initial incentive, but we saw them go far beyond that and turn in very high quality work. Now, you're right that the writing does vary pretty significantly. Brandon and I both, I think, enjoy that writing experience, and that is a significant part of the mentorship on this, is not only helping them identify when they might see overuse, because that was the initial large barrier to this project, is just getting people to be aware that this is happening all around them. And that may have been one of the biggest motivations for me starting this, is I wanted to, you know, I can teach about the statistics and the evidence, but I really wanted other people to see this like I was seeing it around me. You know, when screening tests or preoperative testing, it bothered me when it was wasteful. It didn't seem to bother other people. But when you put it in the context of a patient that got a preoperative chest X-ray and someone was reflective about what happened at the end of that process, and that there could be a harm after finding an incidental finding, and several years later, now we're taking out this adrenal adenoma and it's caused a complication. Was that the best thing for the patient to get that preoperative chest X-ray? It's hard to do that. So, but your question was about the writing, and I think that is a big part of the mentorship. Brandon and I both enjoy that aspect, and so I think that we've had to help. It's variable. Some residents come back to us and it's just a beautiful write-up that's compelling and needs nothing, and we say, you need to submit this to JAMA Internal Medicine. This is beautiful. And others, the writing has been, pretty rough, and it doesn't even make it to kind of the level of local competition. And others were able to help it through. But I think either way, even if the writing is poor, it's a good experience, and it's a good reflective experience for the residents, and a hook for them to continue to talk about value.
No, that's great. So Brandon, I think Tanner's really laid out some of the, the nitty-gritty of it. I would just be curious, it's been now, almost 4 years later, talk about some of the successes you've had, and particularly I'm fascinated with how a project that developed by 2 residents at University of Colorado landed in the editor's lap at JAMA Internal Medicine, such that they were like, let's go for it.
Right.
There's probably a backstory there that I'm not aware of that I think the viewers would be interested in.
Sure. We'll let everybody behind the curtain. I'll have to say that Tanner and I have been as surprised, I think, as anybody. When we started this program, really, it was, we viewed it as something sort of obvious and simple, and our primary aim was to raise awareness, that, as Tanner said, that this was happening, that this was really in the air that we breathe. It's so prevalent that it's actually hard to see. We wanted to change the conversation, and we hope that by getting people to talk about this in a civil, scientific way, that that culture could slowly change over time locally. There was something about it, I think, telling stories and then weaving in the relevant evidence just seemed like such a natural way to talk about medical overuse or value in medicine, that I think others were interested in learning more about it. And so once we saw greater participation from the trainees at Colorado, I don't know, in the first year we had something like 20, 25 participants, we felt like, wow, maybe we're onto something. The feedback has been positive. People seem to be doing a great job. There doesn't seem to be a shortage of stories here. What's the next step? How can we move beyond our local environment? How could we move to residency program next door? Or how can we move to neighboring state? How can we move to the Rocky Mountain West? How can we move across the country? And so we met with a wonderful, very influential person named Patty Gabeau, who used to be the CEO of Denver Health. And we just said, look, we've got this program. We think it's kind of neat. How can we grow this? And she said, well, here's what you could do. Call Rita Redberg at JAMA Internal Medicine and suggest that they create a less is more series for trainees, and so that they can tell stories like those being told in the Do No Harm Project. And so we reached out to them, got on a conference call with them, Deb Grady and Rita Redberg, and they said, boy, this sounds great. Let's do that. And so it's literally as simple as that. And so Teachable Moments was born in 2014. We wrote the editorial introducing the series and introducing kind of the impetus, the motivation for writing these vignettes, and how we think it can really be meaningful to improve patient care. And things have been great with the series thus far. In terms of participation locally, remember, this has been an optional program. This has not been mandatory. We've had about 75 vignettes written at the University of Colorado, 12 of which have been published in JAMA Internal Medicine. And so I think that alone speaks for enthusiasm for participating in this program, and then number two, the quality. 12 of 75 being published in a peer-reviewed journal. I think, these are very high-quality stories, and so we've been very proud of that.
No, that's wonderful, and I'm struck by the cold call to Dr. Redberg over at JAMA Internal Medicine, but it speaks to when you've got a good idea, other people will join and help really spread that idea. And so for everybody who's watching, what we'll do is we'll post the launch of Teachable Moments in JAMA Internal Medicine into the Teaching Value Learning Network website so that people can have access to it and sort of encourage more submissions. Tanner, I think one thing that I would also be interested in knowing, you had mentioned as some of the barriers that you faced. If I'm here and at University of Chicago, one of the things that I do is, I borrow a lot of other curricula and try not to reinvent the wheel. And I know other people are watching because of that. Is there anything you wish you had done differently, had known about, or a barrier that came up that you had not anticipated, either in the spread or in the implementation, that you want to share with us?
No.
Okay.
Actually, there were several barriers that I thought would come up that did not. I have to say that it spread much more widely and was much easier than I anticipated. When you first think about this, you were talking about overuse, and we're talking about something that's a little bit counterculture and being critical of the way that people are doing things around you, and we're having residents think about the practices of their attending physicians, and I thought there might be some pushback in terms of, are we going to open ourselves up to criticism elsewhere, or even lawsuits, or those kinds of concerns, which Brandon and I had carefully prepared answers to the fact that this isn't about mistakes or errors or misuse or surgically operating on the wrong arm. This is something at a higher level that we're interested in. Not that, and those are extremely valuable, and I think M&M conferences and talking about those mistakes are extremely important. But this is something different. This is talking about the optimal care of patients, and talking about things that we do all the time that have negligible benefit potentially, or aren't properly taking into account patient preferences. And how can we think about that and do better in the future? But I'd have to say, honestly, there were far fewer barriers than I thought there would be, and it spread, and I think it may have been a timing issue. We were interested and engaged in teaching about this at a time where I think trainees were more receptive to it maybe than they had been in the past. Overuse and overtreatment, overdiagnosis, overtesting were getting a lot more press than they had in the past, and I think there was a few factors that led to kind of more excitement than we had anticipated even.
Yeah, thank you. I think that speaks volumes, and also to the case-based format that we're already familiar with in residency education, that this can kind of be a really easy way to insert it, as opposed to a full-on curriculum. It's really just case reflection, which I find that to be very elegant. I do have an additional question for Brandon, and I welcome any questions from the audience at this time as well. Just submit them through the chat room. So for Brandon, I know that you've worked on spreading this initiative also through Loan Institute and other organizations. Can you talk about the spread beyond JAMA Internal Medicine and what that impact has had locally as well as nationally?
Sure. So there have been a couple outgrowths of this program, and I think we view the Do No Harm Project not only as sort of an educational initiative, but a philosophy, sort of a slightly different way to think about patients, and that is the best possible care at the lowest possible burden to the patient. So yes, there's been the Do No Harm Project, and yes, Teachable Moments has happened, and that's been great. But there have been some other outgrowths of this line of thinking that I think have been a lot of fun anyway. And so one of those things has been something called Right Care Rounds, which is being promoted by the Lown Institute, and we have a Right Care Educator program that's ongoing around the country. We have 32 residency programs, chief residents participating from internal medicine, emergency medicine, family medicine. We even have a general surgery residency that's participating in this program. And the concept is simple. It's number one, to teach trainees about these principles, about these right care principles, providing the best care at the lowest burden, providing these high-value care principles, and talking about how do you engage trainees around this? How do you have a conversation about this? We're talking about the basic structure of Right Care Rounds, and you can think of Right Care Rounds as Do No Harm Project Vignette meets clinical conference.
Well, I'll just, I think the metaphor of the hook is really important for the Do No Harm Project. It's a way to really deeply engage. We found that some residents have gone on and told us that they've been interested in starting in research careers and studying overuse because of their involvement in this. And there's been a deep engagement from residents. It's been so it's been a really good hook to teach about value and teach about evidence-based medicine through the use of these stories. And so it's been extremely fun, and it's in terms of cost effectiveness ratio, I think the time spent in mentoring residents through a program like this reaps so many returns that it's a very valuable and fun thing to do. And if you have an interest in evidence-based medicine and teaching value, I think this is something to seriously look at, because it's just a great addition to any curriculum or anything, I think.